This conference will now be recorded.
Hi, all. So I just want to thank everybody for being on the line. I thought this was an important topic for everybody because I've been getting a lot of questions about this. And obviously, I think everybody knows that it's been really difficult about getting the information. It seems like the agencies don't seem to be agreeing with each other, and whatever's going on with our political system. I just want to make sure that everybody understands that this is not politically motivated. I just want to make sure that everybody has the right information about these vaccines, the new guidelines by the CDC in terms of quarantine and isolation, because it is different now, and also the capabilities of our office to be able to help everybody to get testing. I've been hearing some kind of nightmare stories from people that they've been running around to urgent cares and emergency rooms, and we are fortunately linked to a laboratories that can actually do the testing in your home. So that way you're not running around. So I'm gonna share my screen in terms of my slides, and we'll get started. And then at the end, we'll have question and answer. Hopefully I've answered a lot of questions, but I'm sure that there will be still some questions, and I'm happy to try to answer them as best as I can. So welcome everybody, and this is the first of on a weekly basis that I'll be doing these lectures so that people get an idea what's going on, because things are really changing day to day, and really by the week there's going to be a lot of changes by that time. But hopefully these will help everybody to be a lot less afraid about what's going on, and that we'll have a better idea of what these vaccines are going to do. So let's see, let me move this over here. Right. So our topic today is about talking about the COVID-19 vaccines, because I'm looking at this is our way, our path to opening our world again. It's really, I started thinking about this and thinking that this is us um, saving ourselves and each other. I think the reason why I'm saying this is that there has been such a disparity about what everybody's doing in terms of prevention. Some are wearing masks, some are not, some are out, some are not, some people are sanitizing, some are not. And so I suppose if we cannot get ourselves on the same page, then there has to be something else that's going to save us from people continuing to die and getting an infection. And you'll see in my presentation what's been happening locally so that you have an idea what's been happening at the hospital for me. I think all of you know that, or most of you know that I'm on staff at Beaumont Troy, and you'll see how our numbers have tremendously increased, and also the comparison of the hospitals in our area. But I do want to focus on the vaccines and the CDC, but it is important to see what's happening to our community. So when we look at just in general information, this is update of information that I received as of this month. If you want a copy of this recorded presentation, please feel free to contact our office, and then we can email that to you. And our ultimate goal is to get a better idea of testing and vaccination, which will help to improve the protection of our health and those around us. So I want to start off, look at our agenda. We want to take a look at the current state of affairs. We want to look at the 3 leading vaccines. We also want to take a look at our COVID rankings and our COVID recovery issues, meaning that what are the acute symptoms that people have and the chronic issues they have. And the reason why I linked it this way is that those 3 vaccines are going to have a big impact on how these COVID rankings, and really ultimately what we're trying to do is not have any more COVID infections that are going to cause acute symptoms and also chronic symptoms in people. And I also want people to understand the difference between isolation and quarantine and the new CDC guidelines for that. And at the end, we'll talk about if anyone has any questions. So the current state of affairs that are related to the COVID, and this is a really very sad statistic, we are having a COVID-related death every minute of the day in the United States. That's pretty significant. I mean, the only other statistic that I see that's similar to that is that on the cardiac side, we have a cardiac event happening every half minute of the day in the United States, and we have a cardiac related death every minute of the day. And COVID now is equal to that. So we need to do something to make this better, because we cannot have people dying every minute of the day of something that can be completely preventable. The other sad statistic is that 40% of the US COVID deaths are related to people being in a nursing home. And it's not just residents that are there. Unfortunately, the medical workers that are there are dying because of the infections. So why is this happening? The reason why is that there's community spread. You have a whole bunch of people in one area, and that you have visitors coming in to see them, and you have medical workers coming in to see them, and now they're in a contained area and they're being exposed to the infection. And the sad thing is that this has been a problem even before COVID came into the nursing homes. We've had infections like pneumonia and flu and other things that have come along that have infected these people in these facilities. And prior to the pandemic, in the data with AARP, it's showing that 8 out of 10 nursing homes were cited for poor infection control. And so it should be natural for us to see that COVID getting into these nursing homes can be a very terrible thing, because if they were already having poor infection control issues prior to that, what more now that we have a decrease in the amount of PPE that's out, meaning that people are having gowns and gloves and masks to be able to protect, and we're putting these people in these places that are going to tremendously increase the risk of infection. The other statistic that was found through the compiling data by AARP is that 1 in 10 nursing homes can only get the COVID results in 24 hours. So if we have somebody that's in these nursing homes and we can't really get anybody in there because of the lockdowns that are going on to decrease their chance of getting infection, and we're testing them, many of them are not getting the results until after 24 hours, which means that we're losing time in terms of trying to get these people cared for. And for these individuals who are at high risk, they have multiple comorbidities, that they don't have that extra time to wait in terms of getting treatment. I'll tell you that I just have a person recently who just had COVID testing in a facility, and they had their testing came in after 24 hours, and unfortunately she was declining, and I had to put her in the hospital. But could something have happened sooner if we could have got the results sooner? I would say that probably that can end up happening. But a lot of times too, we're treating them based on their presentation. So how's their oxygen levels doing? How's their blood pressure doing? How's their heart rate doing? Are their symptoms getting worse? But we have to do better. 1 in 10 nursing homes that can get a result in 24 hours is not good enough. This other statistic they found is that in non-white facilities, they found that 43% had to wait 2 or more days for their testing. I mean, this is just not acceptable. You have these people waiting for a test to come, and they're sitting there exposing more people without the known reason that they have COVID. And this goes even outside the nursing home facilities. I mean, the testing now, where people are going to urgent care and emergency room and they're being tested, and when they're being tested, they're not getting their PCR or their gold standard test for 2 to 6 days, which means that they're either out roaming around feeling that they have a negative test and they're exposing other people and don't know that they're COVID positive because they're waiting for their test, or because they are at home and people are coming to visit them and they're waiting for their test. We need to get these things done quicker. And so I would tell you that I'm very thankful for the lab that we're affiliated with that can get this test done within 24 to 36 hours. And in general, we're getting the results in 24 hours and sometimes even less than 24 hours. And so we get to know that they're COVID positive, we can intervene faster, and they can be out of the community faster so that they're not infecting other people. When they were also looking at the death rate related to people in nursing homes versus what's happening nationwide, it's about 17% of people in nursing homes are dying, as opposed into the general community, it's 5%. So again, it's just re-emphasizing that there is a big danger about people being in the nursing homes because of poor infection control, close contact, that they can't get the results as quick as they should be able to, and and these people are much higher at risk, and so we need to do something to try to protect them. And you'll see later into this presentation that that's actually one of the high risk groups where the vaccines can be focused at. So how do we stay safe? Well, I know that there's a lot of you that are concerned about your family members in these extended care facilities. So I'd encourage you to go to michigan.gov, and michigan.gov in the COVID site has a list of long-term facilities, and you could see at each facility the number of COVID cases that are in each of these facilities. This is really important because if you have to make a decision that the person has to go there for rehab, or it's becoming difficult for that person to live at home, you would want to see that that facility has very low numbers in COVID cases. And obviously the standard things: wash, sanitize, limit contact, social distance, contact tracing, and masks. Locally, this is what's happened. You all know that I'm on staff at Troy. I've been on staff at Troy Beaumont now, 23 years. So I do see people both in the hospital and the office. In the emergency room, things have changed in terms of the admission criteria for COVID positive patients. It used to be before at the start of the year, as soon as someone was COVID positive, they would be admitted. Now, because of the shortage of beds, unless the person's oxygen level is low, unless they can't hold medications down, or they're so tremendously weakened that they can't get up, these people are going to be discharged from the emergency room to be managed at home. And I'm going to show you that there's some things that have now popped up that can improve our ability to take care of people at home. So you have to be extremely ill before you be admitted to the hospital for COVID. There have been a tremendous increase in numbers of patients being hospitalized, and you'll see the numbers that I'm going to show you about the local numbers that are being reported to the government about our hospitalization rates. And I would tell you, being in the hospital, seeing what's been happening, it is true. There are a significant number of patients being hospitalized. There is now limited access to the hospital again. If you all recall, you wanted to try to visit your family member in the hospital, or a friend, and before you could, but then it closed down, and then things opened up when our numbers were going down. But now it's come back to the point that it's very limited access getting into the hospital because of the rise in cases, which is quite sad, because a person who has a family member in the hospital cannot visit with them, especially even if they're very ill. And usually it's only done on exceptions. And unfortunately, the exceptions are when a person's really declining, or they're extremely ill, and that there's a need for the family member to see that person. And that's the time when we make exceptions for people who come in the hospital. I've also seen that there's been conversion of COVID closed units, meaning that in our hospital, and I'm going to get down to the next one after that, we lost our IPR beds. IPR are inpatient rehab beds. That's the highest level of rehabilitation that a person can have, because these people are going to get about 3 hours a day in rehabilitation versus going to a subacute rehab that they're only going to get 1 hour a day in rehabilitation versus going home, and the person might get rehab at home maybe 2, 3, 4 days a week, half hour at a time. So these these IPR beds are extremely important, but at Troy, we closed our IPR floor to accommodate med-surg patients to go up there. And now that opened up a floor in the hospital that's all COVID. So these areas are closed off, meaning that there's a COVID team that manages them to try to decrease the exposure to me and other medical staff members who have not had COVID. And then when they're stabilized after COVID, being in the COVID unit and they've been cleared of their infection, then they're transferred onto our service, which is good because it helps to protect us, which ultimately is protecting all of you, because when I'm seeing all of you, you all want to make sure that I don't get infected too, and that I can infect you. The other thing is happening is that daily I'm getting contacts from the administration of the hospital, as all the other physicians are, is about discharging our patients. I mean, unfortunately, some of our patients have to leave the hospital not as ideal as we want, but it's in trying to opening up the beds at the hospital for the much more critical people that are going there. When you look at the vaccines, there are 3 vaccines that are leading. You have Moderna, which has about 30,000 people in the main study. There are other populations that are being studied, but the main one that they're looking at, it's about 30,000 people. There's Pfizer and BioNTech that has about 40,000 people that are being tested, and AstraZeneca, Oxford University, which is about 25,000 people. These are the 3 leading ones. The Moderna and Pfizer is the form that's the first ever mRNA type vaccine. This is the first time ever making a vaccine in this way. This technology has been out for about 10 years, but they've been trying to formulate it in a way that it could be meaningful in the way that we make medicines or vaccines. In the Moderna and Pfizer form, I'll show you later that they were waiting for the symptoms that developed in these people to see if it was effective. They did find that it prevents disease, but it's unsure if it really prevents infection. So I'll explain that more into the presentation. AstraZeneca is similar to the typical form of vaccines. It's actually a live virus that's been weakened and that's introduced into our body, as opposed to the one that's made by Moderna and Pfizer was never alive. It is actually just a portion of the surface protein of the virus that is now coded by this mRNA, and then it makes our body recognize it or create a wanted poster inside our body so that it would recognize that if that virus that has those surface proteins came into our body, that it would attack it right away. A lot different than the AstraZeneca, because that's a live virus that's weakened and it's actually introduced in our body, and so it's just kind of roaming around in our body until the cells in our body recognize it, and then it starts to form the material to help to identify it and attack it again when it's seen in the future. So the nice thing about the AstraZeneca, though, it was tested for infection of both asymptomatic and symptomatic people, whereas the Moderna and Pfizer vaccines were not testing in the asymptomatic people because they only waited until the person's symptomatic. So the thought is that AstraZeneca can treat people and prevent infection and also decrease the severity of the infection. And that's important to note because that's a distinct difference. Although some of the studies are coming back, but we have to wait because it's still relatively new, that likely Moderna and the Pfizer form will probably prevent infection too. And the reason why it's important about preventing infection and not just preventing severe disease is that if you can prevent infection, you can actually prevent the spread of the disease to another person. If the person has the infection, but you're just decreasing the severity of the disease in them, they still have the virus in them and they can still infect other people. So that has to still be defined by the Moderna and Pfizer um, studies. So in the AstraZeneca, it prevents severity and also infectivity to other people. So let's talk about the first one, AstraZeneca, with in conjunction with Oxford University. It's called AZD 1222 is its call letters in the study. It's a modified DNA virus. Now, DNA is a double-stranded material that actually codes to make things in our body. Without it, we wouldn't live. So when they say modified, what they do is they take the chimpanzee's um, uh, adenovirus, which has not been anything that we've been exposed to, and they modify this so that they can incorporate this into that. That in turn will make something called RNA. When it gets into our body, that RNA now makes something called messenger RNA, and then it encodes the things that recognize the surface of the virus, this protein spike that's on the virus. And once it does that, then it's considered foreign in our body, and our body now starts to make these materials that will attack it anytime it sees it in our body. So if we had anything that looks like it, like we came in contact with someone, it got into our bloodstream, or then our body would go and try to kill it because it's identified. But this is a live virus, and it's weakened and it's introduced in our body. It's done by 2 doses that are 4 weeks apart. In their tests, they were doing nasal swabs to test for infection, whether the person's asymptomatic or they were symptomatic, so they can actually pick up if there was a person who was asymptomatic and see that they had infection. In their study, they found that there were 3 people who ended up having this transverse myelitis, which is a nerve type issue that happened. But when they actually went to dissect out whether the person had the vaccine or they had the placebo, they found out these people all had mostly the placebo, or there was something that wasn't related to the vaccine at all. So it was found that really these 3 potential problems were not really related to the vaccine. The other unique thing about this study is that their placebo wasn't just the saline injection that they injected into people. They actually used another vaccine. It was a meningitis vaccine. And the reason why they wanted to do that is they wanted to try to match what kind of side effects that a person would have. Would it be similar to other vaccinations? Meaning that if a person injects saline into your, let's just say into your arm, I mean, generally it's not going to cause a terrible reaction, like you're going to get a lot of redness and heat at the area, or and maybe even pain. But these vaccines that we have, whether it's the flu vaccine or meningitis or pneumonia vaccine, because they're introducing something that's foreign in there, it can cause redness, swelling, fever, heat to that area. So they wanted to see if this vaccine would do the same thing as other vaccines being introduced. What's interesting is in their study, they found out that when they did 2 full doses that were 4 weeks apart, they found that it was 62% effective about preventing the COVID infection. Now, that sounds like an awful number, but that number is still acceptable to be accepted as a vaccine to treat people. Now, something happened in the Brazil so there were 3 different countries that were studying this. And in Brazil, something happened where they were inadvertently giving half dose as the first dose, and the second dose was a full dose. And when they dissected that data, it turned out that the efficacy of it was higher than if a person ended up getting full doses, 2 full doses. So in the United States, there's actually 2 arms that are happening right now where they're testing where they have, where a person gets a full dose and 4 weeks gets another full dose, and then they have another arm where they have where the person gets half a dose, and then the second is they get a full dose. They want to see if the uh, outcomes are going to be the same. So we're waiting for that data to come in. Some advantages that are going to be with this vaccine are that, one, it just needs regular refrigeration, meaning that it will last for a while under temperatures of 36 to 46 degrees Fahrenheit. So it's not like we have to have any special freezers to go and hold on to this medicine. The other thing is that this group has decided that they were only going to have the medicine that will cost $3 to $5 with a promise not to make any profit during the pandemic. But because of Operation Warp Speed, this vaccine will be free to everyone in the United States. The other benefit to this is that they can make 3 to 4.5 billion doses of this medication, as opposed to the other ones that are much more limited. And you'll see when we get to that. They didn't find any serious side effects, and they also saw no severe COVID-19 cases who received the vaccine, meaning that those people who received the vaccine who developed COVID-19 did not develop severe COVID symptoms. So on average, they're saying that it's about 70% in its effectiveness. So for a live weakened vaccine that's given 2 doses 4 weeks apart, you're looking at about 70% in its effectiveness. And there is the availability to make more of it at a very low cost, and there's really no side effects. The next vaccine, we want to talk about is Moderna. So Moderna is an mRNA vaccine, and again, just to kind of describe that, mRNA is a messenger that contains the blueprint or data that's in there to say, I want you to make this protein. And
It's because this is too close.
sorry, let me change some things here. Okay, hoping everybody can hear me. So let's go back to, oops. Okay, we're going back to Moderna. So going back to how mRNA vaccines work, mRNA contains the blueprint or the kind of the instructions to make a specific protein. And that specific protein in terms of this vaccine is to try to make the proteins that are on the surface of the COVID virus. So these are not alive. They're not part of anything that can come alive. And that, when it's introduced in our body, will then make those proteins that are abnormal and create our body to recognize those abnormal proteins that if we get exposed to them again, our body will attack it and it won't have a chance to infect us or cause disease in us. It's done by 2 doses. You get a dose on day 1 and day 29. And usually if someone developed symptoms, it would be 14 days after the last injection. They found that it was 94.5% effective in its rate. And how they derived that is that they were looking for a number which would create the significant difference that would call it valid in terms of its efficacy. And they said they only needed 95 cases to be able to get that. So they waited until 95 people developed symptoms and were positive for the COVID-19. And then they tried to find out which ones were placebo and which ones were on the vaccine. And they found out that 90 of the people, of the 95, were on the placebo and developed COVID-19 versus 5 of them who were on the vaccine and developed COVID-19, COVID-19. And they said there were 11 of the cases were severe, but then when they found out which group they belonged to, they were all in the placebo group, which meant they did not receive the vaccine. This is pretty significant because those severe cases, not any of them were related to the people who received the vaccine. So what they learned from that is that no one who ended up getting the vaccine developed severe disease with getting the vaccine. There are 1 billion doses that Moderna is planning on making, but that because we have to do 2 injections, that's only enough to cover 500 million people. So it's not enough to go around. There's no significant safety concerns with this. The minimal side effects are the same with actually all 3 of them: fatigue, headache, body aches, redness at the site. And this one has to be cooled down to -4 Fahrenheit for it to last for 3 months. It can prevent the disease in the individual, meaning that you would get the infection, but you wouldn't get the disease of all the symptoms that define the person ill. But it's not sure if it cannot stop the infection. So we're not sure, but they think that it's going to. We're just waiting for the rest of the data to come out on that. And this too, because of Operation Warp Speed, will be free to the United States. When you look at the Pfizer BioNTech, same thing, it's an mRNA vaccine. Just look at mRNA as putting the wanted poster in our body that says, this is what this thing looks like. If you see it, go and attack it. And so that's how we're going to get our immunity from that. It's 2 doses, but they're 3 weeks apart, but you get it on days 1 and 22 versus days 1 and 29. You develop when these people develop symptoms, they would develop symptoms 7 days after the last injection. This one has to be super cooled down to 94 Fahrenheit, so the storage is for 6 months. And the reason why I'm putting this together, the difference about storage, is because something like this is going to be harder for hospitals and pharmacies to be able to really have unless they have a freezing system available in their facility to be able to accommodate taking samples like this. I think there was something that said that if it was at 25 degrees that in storage, that this would only last for about 5 days. So you would have to, you could store it at a warmer temperature, but it would have to be used quickly because it would then not be good after 5 days at 25 degrees. When they did their evaluation, they looked at 94 COVID-19 cases, and they found out they were 90% effective in their rate. They are trying to extend this now to 164 cases to see if the outcomes are the same. So they want a larger number of people with COVID-19 to see if the effective rate stays at 90% or it does improve better than 90%. They did find that there was no safety concerns with it, no severe cases, meaning that the people who developed COVID-19, they were not severe in the ones who had the vaccine. And then the side effects, saying fever, chills, fatigue, muscle aches. They're thinking that they can make about 50 million doses by the end of this year, and they're looking at 1.3 billion doses by the end of next year. Their cost per dose is $19.50 per dose, but again, because of Operation Warp Speed, it's going to be free here in the United States for us. And again, because it's like the Moderna, it's looked at, it can prevent the disease from being bad, but they still have to define whether it can stop infection. And again, we want to try to stop infection because if you are not infected, then your chance of infecting other people is less likely to occur. So the vaccine issues are that the number of doses are available on the proportion of the state population. So that means that the first set that's coming out from Moderna is 20 million doses. So each state's going to get a proportion of that based on their population related to our country. So Michigan is 3%. So we would get 3% of that 20 million doses, just like for all the other vaccines that would be coming out, we would get 3% of that. And then that would be what we would have to use in our allocation for our state. So the initial supply is limited only because even though that they were already making the vaccine over the past several months because they knew it was going to be successful, they didn't make a large amount in case the data came out bad and they would have to destroy the vaccine that they made so far to make a new supply. So they made millions of doses under anticipation that everything would work out, and it did. So they don't have to destroy any of the doses, and they are already waiting for shipment to the military, hospitals, and other places that can accommodate the medication. Now, the CDC is recommending that the vaccinations go first to healthcare personnel and long-term facilities. And I think that based on what you know from the start of this discussion, that there is that very high amount of death rate that's happening in the nursing home or long-term facilities. And hence we want to make sure we protect those individuals, because though it's not just those residents that are being harmed, but even the workers who are much younger and have no medical issues, they're getting harmed too. So the focus will be on them. And then if there's even if there's more, then it would go to the healthcare personnel workers, and then the workers in essential and critical industries. So these are all things that help to support our community, like people in electricity, people in, helping to care for our vehicles, and anything that's critical for us to run our day-to-day operations, they can be covered. And then the high risk and underlying medical conditions. Now notice that the high risk and underlying medical conditions does not designate age, because it could be a young person who has some strong medical underlying conditions that put them at risk, and they should be vaccinated. And then the people who are 65 and older then would also get immunized, and then everybody else after that. There is testing that's being planned, and actually they're going to be starting that soon for those aged 5 to 12 years old and greater than 12 years old. The thought is that it will end up being safe for them too, and the hopes are by 2021 start of school year that the kids will be able to be in school normally and be able to do all their extracurricular activities and sports and band or whatever, that because the vaccine would be able to be used in them, and also for all of us being vaccinated beforehand. They're looking at also in pregnancy, because they want to make sure that baby and mom are protected. So they'll be starting that data soon, hopefully in the next couple months. The COVID antibody positive individuals, so far it's likely recommended that they're not going to get the vaccine at this time, and it will be reserved for those people who are not antibody positive. This hasn't been set in stone yet, but the overall thought is that that you have some immunity for those people who have had the infection for about 3 months. I believe it's longer, because we've seen individuals who probably have tested from being ill a long time ago, and they've been exposed to individuals, and they have not developed their COVID test to be positive, but their antibody is positive. So I do believe that people have longer immunity. And an interesting thing about is the next point is that because the efficacy of these vaccines, particularly the Moderna and the Pfizer one, is so high, meaning 90, 95%, they're thinking that if we had to take boosters of the immunization, we might need it on longer intervals because the efficacy is up to the point which tetanus and MMR are done, in which we don't do those vaccinations until 10 years or much longer if we were to test someone's titers, and that they would need a booster. So we don't know yet about this, but if the predominance is going to be the efficacy of the Pfizer and the Moderna vaccine, then we are probably not going to need the vaccine as frequent as what was suspected. Now, some people are worried about mutation. Yes, there have been mutations that have been going on with the virus, but there are over 1,700 amino acids in this makeup of the protein. So usually the mutations, when they happen, they're happening at one amino acid at a time, and that there would have to be a significant number of amino acid changes in order to change this to not look like the regular COVID protein, to really make it resistant or not useful with the vaccine. So we will be worried about this, but at this time, it looks like that the vaccine should work for a while, unless there's a tremendous change in the composition of the virus. And what I thought was important that I saw is that the majority of events related to vaccines, meaning bad events that happen with vaccines, is usually happens within 2 months of having the vaccination. So it's not usually that something bad happens 5 months or 6 months or a year or 2 years down the road. It's usually whatever's going to happen usually happens within 2 months of the vaccination. And I'm just doing that just to make sure that people are reassured that there's a lot of data out there that says that the vaccines are pretty safe. So I want to go through some numbers that are going on, and this is the reason why this is so important about the vaccine. You can see all these numbers are going up. I mean, look, these are from our lectures that we had since the start of the year. My first one's April 1st, and we had globally 823,000 people that were infected with the COVID virus. And then here it is, December 4th, and there's 65 million. So it went from 800,000 to 65 million. And the deaths went from 47,000 to 1.5 million globally. In the United States, we had 215,000 in April, and now we have over 14 million as what we're talking 8 months later. The deaths went up from 5,000 to 276,000 people who died. And then in Michigan, we had 9,000 cases, and now we're up to 380,000. And the deaths went from 337 deaths in Michigan to now 9,580 deaths here in Michigan as of today. In Wayne County, you could see that there's an increase in cases that went from just shy of 2,000 cases in April to just shy of 68,000 as of today. And then the deaths went from 63 deaths in Wayne County to 3,242 deaths. I'm going to skip down to Oakland County because that's most of us here. We went from 1,900 cases to 49,000 cases, and then the deaths went from 96 to 1,375. And then what's also important is just to look at the city of Detroit. Here is 2,472 cases in April, when going up to just shy of 390,000 cases December 4th. And then the deaths went from 83 to 8,323 cases. I mean, huge jump in just 8 months time. And you can see the numbers from Italy. Yeah, Italy went from 110,000 to 1.6 million in 8 months. And then their deaths went from 13,000 to 58,000. I mean, they're doing something that's curtailing, even though they had such a rapid increase and the death rate was going up so fast. I mean, they did something that ended up helping because they were able to slow their numbers down and our numbers just keep going up. I want to go back up to when you look at the US numbers, just from September 26th to December 4th, we went from 7 million cases to 14 million cases. And we doubled our number of cases in just about 2 months' time. Almost 3 months' time. It's 2 months' time because of the end of September. And when you look at China's data, I don't know how much you can trust into that because, you know, it came from there and then they're going to say that they've only had a 3,000 increase since September to December 4th, and they only had a 7% increase in deaths in that period of time. To me, I don't believe those numbers. So when you look at our rankings, we're still in the top spot for the most cases of COVID. Michigan, we had increased to 17th place, but now we're down to 6th place, which means that we had a significant increase in the number of COVID cases. And in Wayne County, we were like the 9th highest county in the country with cases. And then we got better to 25th place. And now we got a little bit worse. We're in the 22nd position. When you look at Florida cases, Florida went from 6,000 cases to over 1 million in 8 months' time. Our Michigan doubling rate in cases, we were doubling in September once every, or doubling every 109 days. Now our doubling rates every 18 days. So we are not doing enough to try to prevent infection. Our US doubling rate was better in September, where we were doubling every 119 days, and now we're doubling every 28 days. And then our death rate was at doubling every 116 days in September, and now it's doubling every 23 days. So, you know, again, you know, the start of my presentation was really saving us from ourselves and each other, because something's happening that we're not doing enough to protect each other or protect ourselves that are causing all these numbers to go up. And I mean, meaning that our death rate's going, our doubling rate is getting shorter, which means that we're having more deaths than we should be. And same with the doubling rate, it's getting shorter in days. So it means that that's increasing the cases much more rapidly. So when you look at the Michigan hospital data, and I outlined in kind of pinkish or fuchsia color, that's Beaumont because it pertains to me, me being at the hospital. You can see that we have the number of COVID patients we have in the Beaumont system is 688, and there's 8 hospitals across our system. Ascension has 572 across 13 of their hospitals, and Henry Ford has 475 cases across 5 of their hospitals, and University of Michigan has 105, which they only have 1 hospital. The number of COVID cases in the ICU, you can see there, Beaumont has 99 cases, Ascension has 111, Henry Ford has 121, and then the hospital occupancy is anywhere from high 70s to high 80%. And then at the bottom there, you see that I'm putting more pertinent to me because I'm at Troy. We have 178 cases at Troy, 20 of them in the ICU, and 82% occupancy. Now, if you look at, so Troy is 178 cases, and as of today, there's 688 cases that are in the whole Beaumont system, which is 8 hospitals. Beaumont Troy has 25% of the whole number of cases in the Beaumont system out of the 8 hospitals. So we have a lot that's going on. So we're trying to do everything we can to try to stay safe. So the things that I want to make sure that people understand is that the whole idea of doing vaccinations is really to try to cut down your chance you're going to get COVID. And if you do get COVID, that hopefully you don't have these symptoms. And these symptoms, it's presenting as different things: fever, loss of smell, loss of taste, sore throat, congestion, runny nose, nausea, vomiting, shortness of breath, COVID toes, cough, diarrhea, confusion, chest pain, headache, hoarseness, conjunctivitis, which is the pink eye, fatigue, abdominal pain. And then worse is because now we've had a number of people who've had problems that have had COVID long enough now, we're actually seeing them with long-term consequences from the COVID. They're having coagulation issues like blood clots are happening, and brain fog, strokes. They're bleeding. I have brain bleeds or prolonged fatigue or chronic spinning of the room or dizziness. They're developing cardiomyopathy or problems with their heart, having arrhythmias of their heart, scarring of their lungs, pulmonary fibrosis. There's some people who develop diabetes and Alzheimer's related to long-term consequences of COVID. And some of these diagnoses are the ones, and I'm putting this on because there had been some people that have been arguing this point about death certificates and, it's not COVID related. But, a lot of these things here, we're always looking as a reason that caused these diagnoses to happen. So if it was a COVID infection that caused pneumonia, or a COVID infection that caused a blood clot to the lung, a pulmonary embolus, or a blood clot that developed in the legs because the person had COVID, because now they were confined to bed because they were so weak and they developed a blood clot in their leg, because otherwise they would never have developed a blood clot because they were up and mobile and moving around, or it infected their heart and they had weakness of their heart, or they had the confusion, the encephalopathy, or the kidney failure from the dehydration and all the other complications related from the COVID infection, or they had a heart attack, or they had a blood infection, or they had respiratory failure. There was a reason that these things happen. And so the people who argued points on the death certificates and say, oh, they didn't die from COVID, and it's not a COVID related illness, they had a heart attack, or they had a blood clot to their lung. Yeah, well, there was something that precipitated that. And if it had not been they had the infection, then they probably wouldn't have had that condition. And the other thing I wanted to point out too is that we look at our death rate, the number of deaths that we've had in our country, and it's over 260,000. But the reality is that number is likely very undervalued. And there'll be people that argue, oh, they inflated the numbers or whatever ended up happening. Well, if you do all-cause death that happens from year to year, and let's just say back in 1992, and you look around December and you look at the graph and says, okay, this is the amount of deaths that should have happened. And then you look at 1995 and you look at 2005 and you look at 2015, and they all look the same. When you look at this year in 2020, that same time frame that we compared year to year, there's a huge spike in the number of deaths. Well, I haven't heard of anything about a whole bunch of planes going down, or a massive earthquake that happened that took hundreds of thousands of people, along with it. But we do know that COVID came in and took a whole bunch of people. So those deaths, those increase in deaths of all rates, had to come from somewhere. So that's one point I want to make. But the second thing I want to make is that in terms of the undervalue of the number of deaths we had, is there is nothing that's been counted about the losses that have happened because someone's lost a spouse or a loved one, and the consequences that happened to them that caused their health to decline, and something happened, they passed. We hear this all the time about, here's a spouse and someone passes, and then the spouse then doesn't do well and passes after that. Well, I would argue the point, if the person didn't have COVID and didn't die from that, then their spouse probably wouldn't have followed them on the same path and passed because of a broken heart or a sad heart. So I believe that number of 263,000 or so is much higher in the loss of COVID. We just don't add those others, which I think is sad. So I want to go over the CDC guidelines for isolation and quarantine. So the difference between isolation and quarantine is that isolation is for those individuals who have infection. They are positive for COVID-19. And if they do, then they're supposed to start to isolate themselves from everybody 10 days from the start of symptoms or from a positive test if they're asymptomatic. So I'm sure many of you have there's so many cases that are going on right now that you've probably run into somebody who has symptoms and people who don't have symptoms. So if a person who is ill and that other person's being tested and that person doesn't have any symptoms and they turn out positive, then they're supposed, even though they don't have symptoms, they're supposed to put themselves in isolation for 10 days, just to make sure, one, they're not going to start to develop symptoms and get illness, or that they're not going to be shedding the virus and passing it along to other people. At the end of 10 days, you can come out of isolation as long as your symptoms are improving and you're fever free for at least 24 hours. Now, and that's important because that's the minimum time that you have to be in isolation is 10 days. The thought is that if you can go that 10 days, after that, you are not shedding more virus in general, and that you shouldn't be infecting other people. So that's the safe time. But I'll show you that there's a little bit of a nuance or a caveat to that in just a moment. And you have to be fever free for at least 24 hours on that last day. And that means that without the use of Tylenol or Motrin or Advil, that would reduce your temperature. Because if you do, then you could end up still being infectious and you could pass it along to other people. There used to be this, you should retest and make sure you were negative before you be around people again, but that is no longer needed. And that changed in July, that CDC said that you don't need to retest to see if you're negative. Because the reality is that the testing, it picks up both a live and dead virus. And so if you continue to test positive, but you don't have symptoms or you're getting better, then it's likely you're testing positive because it's picking up dead virus, which means then you're not shedding it to go and infect anybody. And again, studies are generally showing that the person's non-infectious after 10 days. So the new quarantine recommendations by the CDC, everyone was getting frustrated because as soon as you came in contact with someone meaningful that had COVID, meaning that under the original guidelines, it was more than 15 minutes and that you were exposed within 6 feet, that they ended up having to be in quarantine for 14 days. They've changed it now to 7 to 10 days. And the way they define that is that if you came in contact with somebody, you go into quarantine for 10 days if you don't get a COVID test. But if you do end up getting COVID tests, you'd have to get a COVID test about the 5th day into quarantine. And that if that is negative, then you could stop your quarantine at 7 days. I still believe that 14 days is best, but it's difficult because you want to work, you want to be out there, you want to do things. So it's nice that they've come down with this 7 to 10 days for quarantine. There's some interesting items. I just thought it would be interesting for people to know these things. Michigan's first case came out March 10th of this year. There's some studies that suggest that vitamin D levels greater than 45 suggest lower positive COVID infections. So, and they saw it in race differences. They saw it in age differences. That in almost every case that if a person had vitamin D levels over 45, they were less likely to end up having infections. There's still more data. There's more studies that need to be done to confirm this, but there's pretty strong evidence that this is probably going to end up true. This illness can last much longer than the contagious period. So people, they're recovering from COVID, but then they end up having symptoms still several weeks into the after they were infected. So you just have to expect that you're probably going to be 14 to 21 days still ill after testing positive. For those individuals who have a lot of comorbid conditions, it's probably going to even last longer than that. And then, unfortunately, there are some people who have now chronic conditions that then will last for months after that, and hopefully not years, but it will last longer. In the and remember I was saying that I was going to tell you about an exception. In immunocompromised people, they might shed the virus longer. So there's a chance that at 10 days, they could still be infecting other people. So people who are on chemotherapy, or they're on medications that suppress their immune system, or they have medical conditions that would suppress their immune system, they probably should be in isolation for longer than 10 days. And they might need to go 14 to 21 days. There's also another change that in people who have been hospitalized, they might need to be in isolation longer post-hospitalization than what the general recommendations are. And then I thought the interesting thing too is that as bad as our economy has been and jobs have been going on, Amazon hired 427,300 employees in the past 10 months because of everybody ordering online, or that there's been a lot of activity online. Now, I did mention at the very start that there's something that has come to my attention. MDVIP has brought to our attention a company that actually is doing monitoring of people. So this monitoring system can be done at home, where it can help to monitor a person's symptoms. It can link them to a nurse that can answer questions if they have any problems. There's some hospital systems that are starting to use this, where they discharge a person because they don't have criteria to be there. It saves their beds. And then this unit that's not needed to hook up to Wi-Fi can report any issues and then alert if the person really needs to be in the hospital. So this is a very interesting technology. I haven't used it yet, but I think that's something we're going to look more into to do that. In terms of testing, you heard from me from at the start that we are fortunate that we're affiliated with a laboratory called RHP Laboratories. They're located in Troy, and they will have a person go out to a person's home, go and swab them. It's the gold standard PCR, and we generally have the results in 24 to 36 hours, and sometimes we'll have it within 12 hours. It all depends on the time of the day that the person's getting tested. The earlier in the day, the sooner we're going to get the test results. And this eliminates the need to scramble for testing, going to the urgent care or emergency room and getting yourself exposed to other people. And it's usually a much higher cost related, because you have to cover the urgent care visit plus the test costs. So it's a lot less expensive. But it's a very quick way that we're getting the PCR result faster than most other places. So generally, if we have to test you and there's a concern, you came in contact with someone, contact our office. Our office then will contact the lab. The lab will then contact you for a time that they can come out, swab you, and then they will report the test to us. And as soon as we get the result, we'll contact you with the result and tell you what else needs to be done, whether you're positive or negative. So if you need more information, just contact my office. So I want to put this up. This is on our Michigan.gov site that shows what's open and what's not open. But I thought it would be important because people want to copy my slides so they can see where we're at. most of the stuff that's closed are things in high grouping of people. So the schools, certain restaurants and dining and organized sports, close proximity, theaters, movie theaters, bowling centers, indoor water parks, bingo halls, casinos, arcades, and group fitness classes. I thought it was kind of interesting that I saw some outdoor classes that were spaced apart on exercise bikes out on 16 Mile Road in Troy. So it was quite nice to see. And then you guys have seen this before about face masks and why they work. This is a cartoon depiction of a person urinating, and if they had no pants and the other person had no pants, then the urine could end up hitting the other person, and they have no protection. Then the person who doesn't want to get exposed to urine is wearing pants. So if that crazy person was urinating, that would get on that person's pants and not on them directly. And then if the person who's urinating is wearing pants and the other person's wearing pants, then the urine would just stay on that person as opposed to going to the other person. And the same concept with the masks. The masks are overall thought to protect us in different ways. Number one, if there's an asymptomatic individual who has COVID and that they're breathing out the virus, then they're breathing it in their mask and they're containing it within themselves. And the other person who's wearing a mask, they're less likely to get hit by the virus in order to get infected. So to end this, we need to take our lives back. A lot of it's been taken away because of this pandemic. And the only way we can end this pandemic everywhere is that we can end the pandemic anywhere. So this vaccine is going to allow us to do that. And the beautiful thing about this is that this is global, and these vaccines are going everywhere, and they're being developed by different countries. So this vaccine is going to end up being available for everyone who wants to take it. And my hopes are is that people have seen the safety profile, they've seen the efficacy, they can see that this is going to be a tremendous new way in developing vaccines with very low side effects, with much more effectiveness, and we can develop it a lot faster. That in almost everything that we do in vaccines, it could end up being this way. And they're actually looking at using this mRNA technique to develop actually cancer medications and maybe other medications. So it's really quite amazing. The entire world has the same goal. We all want to get the COVID cases to go to zero. And the only way to do that is to get antibodies. And the vaccines will help us reach that goal. And I'm just asking everyone to have a little bit more patience. We're almost there. The vaccines are going to be here shortly. We're going to get people vaccinated. And so you need to just keep and do your social distancing, limiting contact, wearing your mask, do your sanitizing, washing your hands on a regular basis. So with that, this is the staff. But I want to open things up for any questions.
Yeah,
Hi, Dr. Calado. Hi, this is Mary Ann Saliba. How are you?
Okay, how are
Can
you?
you hear me? Good.
Yeah.
You know, we've all been through a situation where we're trying to separate ourselves from people and go out into the world as less as we can, so we don't infect ourselves. And you know, myself, I'm doing everything in my power. You know, wearing a mask, wearing everything. You know, so my concern is when this vaccine comes out, I'm going to lean on you to tell me specifically what I should take, because I don't know what to take. And to be honest, I'm a little concerned about it because my concern is that there are medical people out in the world that don't even think we should take the flu shot every year, which I do. I take it every year. And so now we're going to take another vaccine, and whether we've got to take this every year or what, I don't know how this is going to work. My concern is that what is it going to damage in my system already, that when I take this vaccine, what will it compromise in my system? And this COVID thing is really kind of scary. I mean, I don't want to get it. I don't want anybody else to get it. I don't want people to die from this. But we got to take the best hold we can. And if that means we have to take a vaccine, then so be it. But when you already have a compromised immune system, you're scared. I don't know if that's the right word. You're cautious into what you're putting in your body, and that's why I would lean into you to tell me what to do.
So I'm going to answer that in two parts. One of them is going back to the way this is made. I'm going to say I would highly support the mRNA route because that is taking a portion of the surface of the virus and developing the blueprint of it that it now gets introduced to your body. Your body will naturally make that protein, and then your body will make the attacking cells, the antibodies, the T cells, everything that's related to trying to identify it to kill it off. A lot different than, I'm not saying that the AstraZeneca one is a bad one, but it's now a live virus that's introduced in your body and the other one's not ever been alive. So the chance that the mRNA vaccine could make you ill is pretty much zero because it's not a live virus going into your body.
Will
So,
the mRNA damage the DNA that you already have in your system?
no, because it doesn't go backwards. Usually
Okay.
when it's encoding things, it goes from DNA to RNA, and then the RNA becomes mRNA. And so it doesn't normally go in the backwards direction. And that's a part that is important because you're touching on something that's a little bit different on the AstraZeneca one, because it's actually the DNA is now modified to take out a portion that makes the virus replicate or make copies of itself. They take that portion out of it, and then they put something into the code of it, and then they introduce that into your body. Then your body has to go into one part of the cell, and then it goes into something called the nucleus, which is the central portion of the cell, that now it's going to make RNA, which then now comes out of the central part of the cell to go into the regular cell, and then it binds up to these things called ribosomes, and these ribosomes now will make the code to make that protein in order for your body to recognize that and then fight off the infection. Now, so that is a much more complicated way, and that has DNA that's involved with it, and it has a live virus that they have to splice and put all the stuff in it and then introduce in your body. So that's why, to me, I myself wouldn't choose that for myself. I wouldn't choose that for my kids to do, but the problem is we might not have that choice. It might, on the initial go around, those 3 vaccines are going to come out, and it's going to be based on availability on who's going to get it. I mean, I suppose you could just turn it down, that if that's the only one that's going to be offered to you, that you would just turn that down, and that maybe you'll have that choice once everybody else is offered the vaccine, that you can choose which one you want. But I think at the start you may not be able to. Now so that's the first part of it, this understanding how that virus works and why it's so safe. The second part of it is, I would tell you, once I know that a vaccine is available here, how we're going to get it. I would tell you too that the pharmacist downstairs is gearing himself up to be able to get the vaccine. So he's been taking care of whatever for refrigeration, that if he ends up with the Maduro one, that he's going to be prepared to accept it. I mean, he was already prepared to accept it October 1st. No, wait, I'm sorry, November 1st. November 1st. So, but because the FDA hasn't fully approved everything, and they're still going through EUA, which is the Emergency Use Authorization, that should be coming out, and they're looking that they might be actually in distribution within the next 2 weeks. So that's why I want to do these lectures on a weekly basis, so people understood what's happening, on real time, and say that, okay, it's going to come out next week, or it's coming out this week, or whatever's going on. But you will all get a phone blast from me that saying that, okay, here it is. This is where you can get it, and this is what's going to happen. Okay.
Dr. Calado, do you think that this is something we're going to be doing once a year, like the flu shot?
Well, remember at the part of the lecture, because of this efficacy of 95% so high, it is up there with the stuff like measles, mumps, and rubella, and with tetanus. And those are not things that are done yearly. Those are like done every 10 years, or some aren't even done because
Okay.
the thought that immunity is there. We don't
Okay.
know that yet, but they're thinking that it could be once a year, it could be once every 5 years, it could be once every 10 years. It could be that maybe we just have to check your titers, and your titers are dropped, and you get a booster of it. We don't know yet, but we do know that if it's going to be related to those vaccines that are in high efficacy, you might not need it that much. Now, whether that's going to happen with the AstraZeneca, I don't know. That's because it's being reported at 70%. But if they go up to 90% because they change the way they're giving the vaccine as half the dose first, then the full dose is a second, and it truly is a 90%, versus if they do full dose is only 62%, that might change the whole game for that vaccine.
Thank you, Dr. Calado.
Dr. Calado,
Yes.
you can hear me? Okay, one of the things that got on the news in the last few days that I think is going to span the time frame out quite a bit on one or all three of them is the difficulty of the supply chain to keep up with this high demand on the ultimate production line. You have some thoughts on that, and I guess really the related thing is, assuming these vaccines get delayed out and not all available at the same time, like you said, if one becomes available versus two others that are going to come a month or two down the road, I guess what I'm looking for is, how do you feel about one particular vaccine versus waiting a couple months or 3 months or whatever for another one?
I think you guys have known my position is that we need this vaccine, and we need it quickly, and we need to get everyone vaccinated as soon as possible. Maybe AstraZeneca is not as ideal, but we've had a whole bunch of vaccines that we've had as live viruses that we've received for years and years and years, and they've still been good. So I would say that it would be good to get it whenever it's available. I mean, I would say first and second choice would be the Moderna and the Pfizer. I'd reach to those first, and then if AstraZeneca is available and the other two aren't available, I would still get that. There are some problems with the other ones, like Johnson & Johnson's having their issues, but that's why I want to talk about the three front runners instead of the ones that are still trying to recruit people, or they're having side effects in their or potential side effects in their profiles. That these three are coming out really good. So yes, you're right. 20 million doses are coming out on the Moderna, 50 million by the end of the year for the Pfizer one, and then the one for AstraZeneca, you're talking about billions of doses, because that one's going to be a lot easier for them to make initially, or be able to package without freezing and do all this stuff. So I think we're going to end up having the doses quickly, and with this big push by all the governments in the world, all the countries in the world, all the companies in the world, and all of us wanting it to get it, they're gonna get it out. I'm sure we're just gonna have to go through the process of trying to figure out the limited supply at the start. But
Thank you.
You're welcome. Other questions?
I've got one more question, Dr. Calado. Sorry. I envision when the vaccines come out, I envision like a sense of panic and urgency from people rushing out to hurry up and get it. And I can't blame them in a way. I'm kind of like sitting back. I kind of like sit back and want to see what's going on. But My concern is that, I mean, and this is how I feel, and I don't know how you feel, but I would, part of me wants to say, I would rather wait for the good vaccine than to take something that's not so good now. You know, I don't know, that's my feeling.
Yeah, I mean, it's going to be all a preference. I mean, if you're okay about doing all the precautions, you should be okay. I mean, we've been doing it without the vaccine, right? So if we can, it's not like we're going to do anything different. If anything, I think all of us should feel a little bit more comfortable because the more and more people that get vaccinated around us, the less likely we're going to get infected, right? It's not zero, but it's better than what it was before. So,
Right.
and we're still take the same precautions that we did even prior to the vaccines that came out. I just think that what will happen is that over time, as more and more people get vaccinated and things are opening up more, that we're going to start feeling a lot more comfortable and we're getting our lives back. We're getting our
Yes.
country back. We're getting our world back. And then the kids could get back to school because, the teachers will be safe from, all the stuff that's going on. And then the kids, we can everything can get back to normal where they're doing their soccer, basketball, or their other activities. But we're going to get there. I mean, I I knew strongly that once we get the vaccine, and I'm sure there's a lot of people who feel the same way, that that's the way it was going to happen, whether you believe in the vaccine or not. I mean, I explained to everybody the same way. I mean, there are those individuals who decide not to get the vaccine, especially at a time when the vaccine is the most safest way that it's being made, and with much better efficacy and with much less side effects and no serious terrible concerns so far about it. Then those are the individuals who are going to have to be worried about getting infected. They're the ones who essentially have to keep looking around over their shoulder to find out who's around them that they can get infected. I'm not saying that even if we get the vaccine, we shouldn't be worried about that, because I don't want everybody to miss that there are other problems that can happen. And what I mean by that is there are other infections that are out there. Everyone's focused about not getting COVID, but there's MRSA. I mean, there's the flu. There's other infections you can get infected, and you still have to be mindful of being exposed to these individuals, and it's just not COVID.
Dr. Calado, when these vaccines come out, um, are you going to reach out to us and let us know, or I don't know how this is going to work, talk to us personally and let us know what vaccine you want each of your patients to take, because it all depends on their medical histories? Are you going to do that, or how's that going to work?
Well, again, so that's why I'm doing this on a weekly basis, because I knew that a lot of these questions have been coming up, and I wanted to try to address everybody together instead of kind of
Okay.
individually. And
Yes.
I do phone blasts, so what I'll do is I'll send a recording out, though it will go out to everybody at the same time. So we'll just alert everybody, this is what's happening, this is available, this is not available, this is what I'm hoping that you'll do, but I won't know that dialogue until, this stuff starts coming out, and then I can
Okay.
update. I'm trying to update you based on the information that we know now and what we're foreseeing that's going to happen. And I just wanted to
Thank
try
you.
to allay everybody's fears, because, no, everyone's in the dark, and there's a lot of things that are going on with the government that everybody's not seeing eye to eye. And I want to try to, you guys know me, and I wanted you to hear it from me based on what I saw and I feel in my heart and my mind is best to do for all of us.
Thank you, Dr. Calado.
All right, thank you. Other questions?
Yes. Hi, Dr. Calado. I was wondering if I know numerous people have already told me that they're not getting the vaccine. They're afraid of what happens 5 years down the road, or their, children in their 20s or 30s could become sterile, or all kinds of concerns that they have. So if I get the vaccine, my husband gets a vaccine, and other people choose not to, we are still going to be protecting ourselves, though, for a long time with the masks and the distancing. And then am I going to feel more secure that I'm protected from it? So if people around me choose not to be, how's that going to affect me? It still doesn't give me a lot of peace of mind. But these are the same people. I have friends who don't get shingles shots. They don't get flu shot. They don't get any of that stuff. So,
Well, the first thing is I think that you getting the injection with the data showing that even if you end up getting COVID, your infection should not be severe. That should be reassuring, number one.
yes.
Number two, I mean, the fear of all the things about, being with your church group and being with others, you should be less likely to be afraid because, again, even if you got infected, the chance that you would have a severe type of COVID infection would be pretty low. I mean, to almost zero. So you should be able to feel a lot of comfort in that. Number three, the way you are and you're afraid of getting an infection, then I would assume that you would do all the things you would to try to not infect other people. So you're going to hand sanitize, keep your social distance, or wear your mask and stuff. Just the same things just to protect them because I know your heart is in that place to go and protect them too. So if anything, it's going to take where you're at now and should make you feel a lot more at ease than where you are. And I know that you don't feel that way, but once you get to the point that you can get the vaccination and you can start to see how things are going to be much more relaxed for people, I think you'll see it then.
Sounds good. I like that prescription.
I think all of us do, right?
You do. You know me well. Now other people do too.
Okay.
Dr. Calado, when will you have the recording of this available? Because we do want to get this to some of our family members and that to look at.
I think it'll be probably within 5 minutes of us ending. Yeah.
Okay.
Yeah, my IT
But
person.
do we need to call the office to
Uh,
get it?
But no, I think so. Bernadette's planning on emailing it to everybody once it's
Oh,
available.
okay. Thank you.
Oh, no, thank you. Other questions?
Well, the caller that just spoke, the young lady that just spoke a few seconds ago mentioned something kind of important, but I don't think you're going to be able to answer that question. But it has crossed my mind is that you go take this vaccine whenever it comes out, you go get the vaccine. But we don't know the problems that might incur from this vaccine 5 years down the road. We won't know because we're the guinea pigs, we're the people that are taking the vaccine from the get-go. So I think that when she asked that question, what would the side effects be 5 years down the road, we really won't know that.
The answer to that is you're right, but at the same time, when you look at the process of how these mRNA vaccines are being done, it is
Okay.
almost as if it's mimicking very natural to the process that our body would do, but do it in advance.
Okay.
And it's like, okay, if you're looking for someone, we do this in for people who are unlawful. We set up a wanted poster for them and say, okay, be on the lookout for this person, right? So this is all this this vaccine is doing is creating our body's ability to do that. So let me put it this way. If you have the infection, that virus has that protein spikes all around it on the surface. Your body is going to recognize that without the vaccine, and it's going to try to fight it. Now, if it does a very good job about it and can catch it before it goes and infects the lung cells that it does, then you have a chance to actually do pretty well.
Right.
But by the time your body recognizes it, it might have already infected your lung cell and then created a lot of havoc that now you become extremely ill that maybe you can recover or maybe you can't recover. Okay, so but once that ends up happening, your body recognizes it, it's going to do the same things that the virus did in terms of making this whole cascade of events to happen so it could recognize that protein surface of the virus so that you can make the cells to fight it. The difference is that this vaccine's manufacturing that sooner by saying, let's take and strip the proteins that are on the surface of that virus, and let's make the blueprint that says, okay, this is what it is, make that into the body in advance. And so your body can now start to create the cells that are needed to fight it without putting the virus in your body.
Okay.
See what I'm saying?
Yes.
So it's a very natural, more natural way of your immune system developing that without that big rush to do it.
Okay.
Because
Thank you.
when we get the infection, we have this big rush that our body's supposed to do it. But if our body can't keep up to do it because maybe we're under the weather and our immune system's already being overly worked and it's working on something else and it can't do that, and we get overwhelmed, or our immune system's not good in the first place because we didn't know we had an underlying medical condition, they were immunocompromised, or we can't make antibodies. This all could be done in advance.
Thank you, Dr. Calado. Thank you.
You're welcome. Other questions? So if there's not any other questions, I just want to thank everybody, and especially that there's probably some angels still on this call, and you know who you are. You've done tremendous things to help our practice and help me to become a better doctor, and I just appreciate each and every one of you. So if you guys have any questions, reach out. Please don't wait too long, because I don't want you to develop symptoms so bad and we're trying to play catch up on a lot of stuff. So please be safe. Happy holidays to everyone. Just gonna ask again, no one has any questions before we go?
Just want to say, I appreciate you so much, Dr. Calado. Thank you for all you do, and thank you for really caring and loving your patients.
It's a great joy to me. So
Frank and I second that emotion, and we appreciate you very, very much, Dr. Calado. Thank you so much.
Thank you so much, Doc.
Thank you.
thank you all. So again, we'll do this weekly, and so that way, hopefully the next ones won't be so long, so that we're just going to be an update on things. Okay. Take care, everyone.
Thank
Happy
you,
holidays.
John.
Bye. Thanks.